Yes, thanks again for the invitation to speak and update you on nitrous oxide. My apologies in advance. I've come here with a terrible virus and I'm feeling terrible, not very well. So I'll do my best to get this across to you this afternoon. And thank you for your patience this afternoon. It's been a great day, but a long day. So it's actually proving to be a big year for nitrous oxide in terms of the evidence basis that we have for it, which is evolving very fast. But I need to just recap on some of the issues I spoke about last year relating to the fundamentals of the basic science and the pharmacokinetics of nitrous, because it's a very important part of the whole equation as to why we continue to use nitrous or think about using nitrous is its pharmacokinetic properties. And I'll just briefly recap on those things. Up to 20, 25 years ago, nitrous oxide was routinely used for most general anaesthesia. It's a weak anaesthetic, but it had analgesic properties, and its low solubility gave it very favourable pharmacokinetics with rapid wash-in and wash-out at the end of surgery. And in an era when the older volatile agents had significant cardiovascular, in particular depressive effects and toxicity, its dose-sparing effects were seen as desirable. In the modern era of the more modern agents with their better pharmacology, the pharmacokinetic advantages have obviously reduced. Desflurane and sevoflurane have wash-in and wash-out times which are comparable to that of nitrous oxide in most modelling that you do on this sort of thing, computer modelling. And in terms of the dose-sparing effects, the better cardiovascular profile of the newer agents probably means that the focus on dose-sparing effect from nitrous oxide should look more at cost and environmental issues, and we'll talk about those later on. Nitrous has rapid wash-in and wash-out characteristics from the body, as we said. This is driven in part by its low solubility in blood and body tissues, but also by the concentration effect, which is the boost to the rate of rise of alveolar concentration that you get when you deliver a gas at a high concentration as opposed to a low concentration. The other interesting and unique property of nitrous oxide is the second gas effect, and we spoke about this at a bit more length last year, but once again, just to recap, it's the acceleration to the rate of rise of alveolar concentration of the other gases in the alveolar mixture, the volatile agent and also the boost in alveolar oxygen concentration that the rapid uptake of nitrous oxide produces, particularly in those first several minutes of anaesthesia, and that's due to a concentrating effect that the uptake of nitrous has on the other gases in the alveolar compartment. The second gas effect is nothing esoteric or theoretical. You can demonstrate it quite easily using standard monitoring tools on any modern anaesthesia machine. But importantly, you need to understand that the real effect is the effect on arterial partial pressures, not on alveolar partial pressures. And in fact, we've shown that the arterial partial pressure is the second gas effect on arterial partial pressures is a lot more powerful than that which we see reflected in the expired breath. And that's simply because most of the uptake of nitrous oxide is occurring in these lung compartments with moderately low VQ ratios. They're the ones that get most of the blood flow. That's where the perfusion-driven uptake of nitrous oxide and the other gases is occurring, that's in fact, and they determine the composition of arterial blood leaving the lung. So, in fact, that's where, if you actually take the trouble to measure the effect in arterial blood, this is what you see, and what we measure in the expired breath is only a pale reflection of that. At the end of anaesthesia, the second gas effect works to our benefit in the opposite direction by a dilutional effect, washing out, accelerating the washout of the volatile agent from arterial blood into the alveolar gas and into exhaust. And once again, we've shown this to be the case in a series of patients where we measured arterial sevoflurane partial pressures. And the effect seems to be maintained into the recovery room. And you don't need a big study to show that there's a demonstrably quicker wake-up time using a standardised extubation protocol in patients who have had a maintenance nitrous oxide anaesthetic as opposed to a nitrous-free one. So that's pharmacokinetics, but I want to spend time today talking about the overall risk-benefit equation with nitrous oxide and how that's evolved. Traditionally, back in the good old days, there were a few relatively rare contraindications to the use of nitrous oxide, which were all taught. Patients who couldn't tolerate the lower FiO2 that accompanies nitrous use because of impaired gas exchange, patients with severe pulmonary hypertension, patients with gas-filled cavities, pneumothorax, pneumocephalus, that sort of thing. Patients in early pregnancy or the chronically ill or immunocompromised, we were taught to avoid nitrous oxide. And that was because of the known propensity for nitrous to inhibit the methionine synthetase enzyme system, folate cycle and the SAM cycle. The folate cycle is responsible for generating precursors for DNA synthesis, and this leads to immunosuppression if it's suppressed. The SAM cycle generates methyl donor groups for a wide variety of important synthetic functions in the body. And interruption of the SAM cycle leads to accumulation of homocysteine as an intermediate metabolite, which is responsible for causing endothelial dysfunction. We'll talk about that in a moment. In ENIGMA 1, which was published several years ago, a trial of 2,000 patients randomised to nitrous oxide anaesthetic or a nitrous-free anaesthetic with a high FiO2 of about 80%. We actually showed that there was a significant difference in wound infection rates and also pulmonary complications. And that seemed to be in line with the theoretical considerations to do with immunosuppression that we just spoke about. The different FiO2 in the two groups, it was a bit of a confounding factor, and it's caused a lot of confusion because there was evidence that FiO2 is an independent factor which can affect wound infection rates, but the data on that's very mixed, so I won't dwell on it. I'll talk more on the cardiovascular complications. We showed in ENIGMA 1 that you get a progressive rise in homocysteine plasma concentrations with increasing duration of exposure to nitrous oxide. Quite a significant and reproducible finding in a subgroup of patients in the trial. This can be shown to be associated with endothelial dysfunction, and there are various tests that you can do to demonstrate that, but the usual one that's done is what's called flow-mediated dilatation, where you put a cuff on the forearm and you look at the response to cuff occlusion of Doppler brachial artery flows, and exposure to nitrous oxide produced a very different pattern of response to the control group in that trial. And this is a standard technique for demonstrating the concept of endothelial dysfunction, which is thought to be associated with the risk of cardiovascular complications. So this all made a lot of sense. ENIGMA 1 wasn't powered to look at cardiovascular complications, though. There was a non-significant trend towards an increased rate of myocardial infarction in ENIGMA 1 with a almost 2-to-1 ratio, but we needed a bigger trial. Interestingly, at the 3.5-year follow-up study for the ENIGMA 1 trial, there was an increased rate of myocardial infarction in the nitrous group. What that means, we don't know. No difference in mortality or stroke, but it was interesting. So ENIGMA 2 was embarked upon. The inspiration of my colleague Paul Miles at the Alfred in Melbourne, who was the PI. 7,000 patients internationally across a couple of dozen hospitals in 4 continents. It selected a high-risk group who had significant cardiovascular risk factors, undergoing major surgery, randomised to nitrous oxide versus no nitrous oxide, and both groups in this case got an FiO2 of 30%. The primary endpoint was a composite endpoint of various cardiovascular outcomes: death, myocardial infarction, stroke, PE, cardiac arrest within 30 days of surgery. All patients got serial troponins and an ECG for the first 3 days post-operatively. The results were published in Lancet just a few weeks ago, so you may already have seen them. But this is a true negative study. There was no signal at all of an effect of nitrous oxide on any of these cardiovascular endpoints. I was quite surprised. I thought the case for this study was very good, but it's not there. Nitrous oxide appears to be devoid of any significant cardiovascular toxicity whatsoever. Interestingly, there was no evidence of an increase in the risk of surgical site infection either. So it's quite at odds with ENIGMA 1. No difference in the rate of fever as well. We didn't look at pneumonia in this trial, unfortunately. We should have done so, but certainly there's no difference, no suggestion of a difference in sepsis at all between the two groups. So is the different FiO2 between the control groups in ENIGMA 1 and ENIGMA 2 responsible for this difference in outcome in terms of infection risk? It's a complicated topic. Suffice to say there have been several trials of looking at the relationship between FiO2 and wound infection rates conducted in a number of centres worldwide with very mixed results. The largest study to date was the proxy trial conducted by a Danish group with 1,400 patients randomised to an FiO2 of 30% versus 80%, and they found no relationship between FiO2 and wound infection rates. So we don't think that the FiO2 explains the difference between ENIGMA 1 and ENIGMA 2, and I think the finding in ENIGMA 1 of an increased risk of wound infection was probably type 1 error. It was a secondary endpoint. The p-value was 0.04. And these things happen when you do multiple sampling looking at different endpoints. So that's where we are with that. There are some other endpoints that we looked at in ENIGMA 2, post-op nausea and vomiting. So we'll talk a bit about that as well, because it's a slightly more complex issue than what we've been taught, I think, traditionally. It's been recognised for many years now that nitrous oxide does contribute to PONV. This is Martin Tramer's meta-analysis from the 1990s, which first documented that this was the case. Problem is, it's a very heterogeneous body of literature, this. There's a lot of very small underpowered studies. The bottom line is, if you want to investigate even a common endpoint like PONV, which occurs in 30% of patients who are untreated with prophylaxis, you need 500 patients in the study. It's very simple. Go to any stats package and it'll tell you need 500 patients in the study, but there's at least two dozen studies that get into these meta-analyses where people have done 50 patients, maybe 100 patients. And the risk here of publication bias, I think, is enormous. And in fact, this more modern meta-analysis by Fernandez Guasozola certainly doesn't provide any reassurance that we don't have a problem with publication bias when it comes to PONV and nitrous. However, I think this is one way to make sense of the issue and this widely varied results. There is a significant relationship between duration of exposure to nitrous oxide and your risk of PONV. And in particular, the results of the large studies, the ones that were adequately designed and powered, fit this line of best fit very nicely. So this is a meta-regression that we published earlier this year in anaesthesiology using a random effects model and a highly significant relationship between duration of exposure to nitrous oxide and your risk of post-operative nausea and vomiting. And in fact, with less than an hour of exposure, there's really no effect at all. With more than 2 hours of exposure, there's a significant effect, with a number needed to treat of 9. So the risk increases by about 20% per hour, but under about an hour and a half of anaesthesia, there's no significant contribution to PONV from nitrous oxide from the published data. What did ENIGMA 2 find? ENIGMA 2 found, indeed, overall, that the risk ratio of PONV with nitrous oxide was 1.35. It was highly significant. Interestingly, if you looked at the patients who got antiemetic prophylaxis routinely versus those who didn't, and about half the patients in the study were given routine antiemetic prophylaxis by the anaesthetist just on the basis of standard practice, their standard practice. In fact, the patients who got routine prophylaxis, there's no significant effect from nitrous oxide on the risk of PONV. If you didn't get that, then there was a highly significant effect, and the interaction between those two groups is highly significant. So, in actual fact, it would appear that nitrous oxide PONV with prolonged exposure is real, but it's readily managed with routine measures that probably should be a part of our standard practice anyway. How does the E2 data fit in with the previous graph that we looked at from the previous studies, meta-regression analysis? Well, it actually fits that line of best fit very nicely. So it strengthens the duration-related hypothesis fairly closely. I'm actually wanting to propose a different mechanism for nitrous oxide-induced PONV to what you've normally been taught. We talk about opioid receptors and gastric distension and whatnot. That progressive rise related to duration of exposure to nitrous parallels the rise in homocysteine levels. And in fact, if you give patients homocysteine as part of a methionine provocation test, they feel sick quite commonly. I think, in fact, the real mechanism relates to the increasing concentration of homocysteine that we know is generated by nitrous oxide, which doesn't seem to cause other toxicities, but I think it probably does cause PONV. And this is data from published by Peyton group in Washington, which I found fascinating. They were once again looking at cardiovascular endpoints, and they took 500 patients having a nitrous general anaesthetic, and they randomised them to folate versus placebo, and they did homocysteine levels and various things, looking at cardiovascular outcomes. They also looked at the rate of PONV, and they actually didn't report this finding except in their table 4. But the group who got folate prophylaxis had a 3/4 reduction in their risk of PONV compared with the group who got placebo. This is quite compelling evidence that, in fact, it's homocysteine, or the interruption of the homocysteine SAM folate cycle, which is responsible for nitrous-induced PONV. And I think it's worthy of further prospective investigation, actually. Let's just talk briefly about costs, because cost is an issue with nitrous. We're told it's a cheap agent and it reduces the cost of the other agents, the volatile agents that we use. We did a cost-benefit analysis after the ENIGMA-1 trial, based on the results of ENIGMA-1, which showed that the administration of nitrous increased the hospital-related costs per patient by about $2,500. And this was related to the increased rate of wound infection and also a slightly slower rate of discharge from ICU that we documented in ENIGMA-1. Frankly, this needs to be reassessed in light of ENIGMA-2. I don't think, in fact, that we can support that finding. We did use a calculation of consumption costs for nitrous oxide in that paper, which roughly estimated that 1 litre a minute of nitrous oxide costs about $1 an hour in terms of supply costs. This table is something that's hung in all our operating rooms at the Austin in Melbourne. It's put there just to remind people about the relative costs of the agents that they're using on a daily basis, not just volatile agents, but I've just focused on that part of the table here. And ENIGMA-2 data showed that using nitrous oxide reduces your consumption of volatile agent overall by about 35%. So it's not quite 50%, 35% is what we've found in this quite large sample. So if you look at that supply cost of nitrous and compare it to these consumption costs of the three modern volatile agents, you can calculate that there's actually little supply cost saving at all to be gained by using nitrous oxide with isoflurane or indeed with sevoflurane at low to moderate fresh gas flows. However, if you're a desflurane man or woman, your anaesthetic is costing about 10 times what a nitrous oxide iso-sevo anaesthetic would cost. So if you like using desflurane because of its pharmacokinetic advantages, you're doing so at considerable cost. Now, the reason I bring this up is because we've actually audited our consumption of the three volatile agents in Australia over the last 7 years, and this was published just recently in Anaesthesia Intensive Care. And what we've shown is that there's a progressive and inexorable rise in the proportional usage of desflurane in Australia, or Victoria specifically. I'm sure it's something that's probably common to most developed countries. Desflurane's becoming increasingly popular because everybody likes their patients to wake up nice and quick at the end of the operation. We all love that, and desflurane's becoming more and more common. So this is associated with a progressive rise in costs of inhalational anaesthesia in Australia. I won't show you that graph, but it parallels this trend line. I'll just briefly talk about greenhouse gas issues. In fact, I won't dwell on this because Jeffrey's dealt with this quite eloquently already. This is the graph from Jody Sherman's paper, which compares the costs of the greenhouse properties of the three different agents that we use. The increased greenhouse footprint of desflurane relates largely to its longevity in the atmosphere as well as its radiative forcing properties. And nitrous oxide, as we know, is a potent greenhouse gas. It's estimated about 1% of nitrous oxide production is medical. The rest comes from aviation and agriculture. So it has to fit into that bigger picture, but it's not negligible. Just doing a rough calculation about the global warming potential of a typical inhalational anaesthetic. In fact, desflurane is worse than your typical nitrous oxide, SEVO or isoflurane GA in terms of its GWP footprint. Probably about twice as bad, roughly, as nitrous. So nitrous is a bad guy in this regard. Desflurane is a really bad guy, and I personally can't see any justification in outlawing nitrous oxide because of its environmental credentials without taking away desflurane as well. That's going to be a controversial comment, I know, but I think it's defensible when you look at those numbers. We should probably use less of both. The question is how do we use them? But there's one more element to put into the mix here, which I'll just briefly mention because I talked about it again last year, and this is one particular aspect of the nitrous oxide story that I can't provide you with fresh information on, unfortunately. In ENIGMA 1, Matthew Chan in Hong Kong found that the rate of severe post-surgical pain in patients in the Hong Kong cohort of ENIGMA 1 was about 10%, and in fact that risk was halved if you were in the nitrous oxide group, which is just flabbergasting. It's quite a dramatic finding, presumably related to its NMDA receptor properties. I won't go into those details, but we've certainly been pursuing this very hard in ENIGMA 2. I think we'll have about 3,000 patients worth of data in the one-year follow-up study from ENIGMA 2. That's just been completed now. By the end of the year we should have those results, and we'll know if we can replicate that finding from ENIGMA 1 in the ENIGMA 2 study. But I can tell you that the rate of persistent post-surgical pain across the board in ENIGMA 2 is about 12%. 12% of patients having major surgery complain of persistent post-surgical pain a year after their operation. And in about half of those, they rated as worse than 5 out of 10. So this is a significant problem, and it's been a bit of a sleeper issue, one that we haven't wanted to know about as a craft group, but I think we need to start taking some ownership of it. And particularly if nitrous oxide turns out to be the most effective agent at dealing with this in a preventative fashion, then as anaesthetists we definitely need to know about this, because we're the guys who are going to be in charge of the nitrous oxide flow meter. So we need to know whether this is real, and we'll know soon whether in fact nitrous oxide does have this effect, and then we'll be able to make some decisions about how it fits into the bigger picture, because this is an important endpoint. So in summary, the pharmacokinetic advantages of nitrous oxide have been underestimated in the past, I think, and they shouldn't be dismissed. They are real. The toxicity of nitrous oxide in patients having elective major surgery appears to be negligible, despite intensive investigation. And those side effects that we do know happen, such as PONV, appear to be quite manageable with simple prophylaxis. So the list of contraindications to the use of nitrous oxide has returned largely to the one that we were taught traditionally 25 years ago or more. We can probably add laparoscopic surgery to the list, because obviously bowel distension is unhelpful in that situation, but it's the traditional contraindications still remain. Its environmental impact is not negligible, but certainly if we're going to continue using nitrous, low flow, preferably automated low flow systems, are going to be an important part of being able to do that responsibly. And I'm looking forward to being able to provide you with some definitive information on the issue of post-surgical pain, persistent post-surgical pain next year. So thank you very much for your time.